Embark on the formidable voyage through the realm of ophthalmic prowess as we unveil the remarkable tale of a teen thrust into the tempest when an innocuous schoolyard feud threatened to change how she would see the world. Traversing a labyrinth of medical consultation before reaching our care, what confronted us was a myriad of traumatic sequelae that posed us in baffling concoction to determine the right course of action. With traumatic glaucoma being kept in bay by anti-glaucoma medications, we began the difficult task of tackling other challenges, that is the traumatic cataract, iododialysis and the mydriatic pupil. The question remained, can the paradise lost be regained? After deliberate consideration and visual rerunning of the calculated approach, I proceeded with the surgery. A temporal 2.8 mm clear corneal incision and paracentesis were made. Capsulorhexis with cystotome was then performed. The smooth progression of cystotome ensured good zonular integrity. Being a soft cataract, this was hydroflipped into the anterior chamber and was aspirated with coaxial IA handpiece. Following an adequate cortical cleanup, the multifocal IOL was injected and placed inside the bag. Now comes the mammoth task of restoring the anatomical shape of pupil. We start by using microforceps to grab the pupil edge forward to see how much iris tissue is present and also to check its distance stability. While evaluating the residual iris, there was a radial tear noted at 7 o'clock position. Here a double-arm, straight needle ninoprolin suture is used. Starting from the nasal paracentesis, I introduce the prolin needle within the forceps to prevent inadvertent incarceration of corneal or iris tissue in the needle. For pupil circlage, we may take multiple bites through the iris tissue around the pupil. These bites should be as close as possible. The microforceps is being used to grasp the iris tissue to pass the needle through. Once we come to the end of first segment, the needle is taken out by rail loading into the viscocannula. The maneuver should be done very gently without causing any traction onto the iris tissue, as any break or tear at this stage will lead to restarting the procedure from beginning again. Then we introduce the second needle for the second segment of the atonic pupil. It is important to replenish with viscoelastic on a regular basis to keep the anterior chamber well formed. Similar close bites less than a millimeter away from the pupillary margin are taken. After this, the needle is exteriorized through the main wound. The first needle is then exteriorized and reintroduced through the adjacent paracentesis for the ease of mobility. It is important to use the incision as a fulcrum to prevent the corneal striae, which can hamper the visibility of anterior chamber. After completing the third segment, the needle is exteriorized through the main wound. Then both the needles are cut off from the suture. Now the ends of the suture are looped to make a knot, following which shorter end of the suture along with the knot are taken back into the anterior chamber. Then I used a forceps through the paracentesis. The knot is tightened and titrated in such a way the adequate 3 to 4 mm pupil size is achieved. Once it is done, we can see the pupil is eccentric and the superior iododialysis is more evident. Now we proceed to repair with the iododialysis. A superior scleral groove is made around 1.5 mm from the limbus and a double-arm straight needle of nylon suture is used to repair the iododialysis. Once the repair is complete, we can see the eccentric pupil is now centered with a good IOL centration as well. Uncorrected visual acuity of 6/6 and N6, the continuous range of her youthful vision regained in all its majesty, with nil dysphotopsia.